why has it been so difficult to target KRAS? So we know that KRAS is a very important node in a sequence or a pathway. And when you sort of try to target upstream of the pathway, you get bypass tracks or these sort of, other avenues that develop where the tumor can still signal. So when we look at upstream inhibitors, right, as you see listed here, such as farnesyltransferase inhibitors, we're really unable to effectively block RAS. When we look downstream, right, of KRAS blocking maybe RAF or MEK or ERK, really also very limited duration of response. And when we've looked at directing KRAS inhibitors specifically to RAS itself, been very difficult to inhibit that pocket. And it wasn't until 2013 in Kevon Shokat's group in the West Coast where they were able to develop using medicinal chemistry. So, tweaking the chemistry of a molecule to specifically block one residue, a cysteine residue, which is an amino acid in KRAS, to successfully block that pocket to prevent signaling through that. And this is really the story here, right? So we're now able to have a covalent inhibitor, a therapy that's able to bind the cysteine residue in this complex pocket and able to render this in the inactive state to prevent signaling through this pathway. So how is this started? And where are we now? I mean, we all know these memes. Going back to ASCO 2019, we saw data presented for AMG 510, now known as sotorasib. This was the last day of ASCO. Most people had already head home. And you see the initial response curve. So each one of these bars in this graph represent an individual patient, and bars that are downgoing represent response or regression in the tumor lesions. And what was really exciting to see is early on, we saw that 50% of patients had a radiographic response to this small molecule, sotorasib. And really this opened the floodgates of many interesting and novel therapeutics in this space. So how is it going now? We now have 2 FDA-approved therapies with sotorasib with a response rate of about 37%. And more recently, adagrasib with a response rate of 43%. More recently, we've seen therapies divarasib as well as LY982. So very early on in development, doesn't even yet have a name, with similar response rates. So I think these are the early days of the targeted therapies in KRAS. We are nowhere near where we are in EGFR, where we're seeing response rates of 80%. We're still seeing response rates here in that 30-40% range. So more needs to be done in this patient population. Just like Dr. Prishikal showed us some data from ASCO, I want to show an updated data set from ASCO. This is JDQ443, which was just presented. Again, this is a KRAS G12C inhibitor. This would be the 6th one now in development, which showed a response rate overall of 57.1% in those patients who received the dose of 200 milligrams twice a day. It's important to note that this is still very early on in this trial, and we need to better understand how these medicines